too. So without further ado, I'd like to introduce Dr. Diana Dolan. She is an Assistant Director of Training and Education at the Center for Deployment Psychology. And in her current role, she assists with oversight of the SBHP program and develops and presents some of the SBHP trainings. Dr. Dolan is a veteran of the United States Air Force, and she's certified in behavioral sleep medicine by the American Board of Sleep Medicine. She's also a diplomat in behavioral sleep medicine from the Board of Behavioral Sleep Medicine. She joins us today to discuss addressing chronic pain through the use of pacing in military populations. Welcome, Dr. Dolan.
Hi, well, thank you all for having me on. I'm so excited for a chance to talk to you all. I really appreciate your time and I appreciate you all being SBHP providers. So I'm so glad you all are here today. And I'm really looking forward to talking with you about pacing as a particular intervention for patients with chronic pain. I'm going to be talking a little bit about kind of the range. There's a host of interventions for chronic pain. Some of them are variations of strategies you all probably are already experienced with, like addressing cognitive aspects that are not helping the patient. But there are some aspects of treating pain that are often brand new or not typical with other protocols that you might use. And so I thought it would be helpful because a lot of our military connected patients do have pain to talk a little bit about what pacing is, what it looks like, how it might help your patients in particular. As we go along, I'm going to be keeping an eye on the chat. So as we go along, please don't hesitate to put questions in the chat and I will get to those as I go. I also have my coffee here, so I will pause periodically for sips, but we will go through. I do want to acknowledge before I get going that a number of the slides are adapted from the Cognitive Behavioral Therapy for Chronic Pain workshop that CDP developed a couple of years ago that myself and another colleague, Dr. Sharon Berman, worked on. So I do want to acknowledge where the slides come from. All right, so I guess we'll go on to next. And Jennifer, I think I may need to rely on you to hit next, if that's okay. Oh, thank you. All right, so just to give us a little bit of background on what we're talking about, when I talk about interventions for pain, I'm referring specifically to chronic pain. When we talk about behavioral treatments for pain, again, we're talking about chronic pain. So we might all have pain related to an injury or some sort of mishap. And that's not uncommon for folks to experience acute pain. What we mean when we say chronic pain is pain that's gone on for an extended period of time. And right now, the current definition of that is greater than 3 months. When you look at folks with chronic pain diagnoses, some of them may have an ongoing underlying medical condition. For example, some people may have chronic pain due to a slipped disc or fibromyalgia or something like that. You may also have people that have chronic pain that the medical condition does not fully explain what's going on, or that the medical condition would have been expected to resolve. For example, I have some folks that develop chronic pain after a surgical procedure. And after that period of time when we would anticipate they've recovered, they're still experiencing pain. And so when we get to that point of someone having chronic pain, by definition, the chronic pain has kind of taken on a life of its own. So if you're looking at treating patients in acute pain, that's something that patients would follow up with their medical providers for. They may be told to rest or to take medication or various other kinds of interventions. Well, again, what we're talking about today is chronic pain when folks have gotten to that point where the pain itself is the focus of intervention and not an underlying cause, if you will. All right, so we'll go on to the next. When you look at treating chronic pain, and thank you, I always forget this slide is animated, but it's kind of nice how it pops up. When you look at treating chronic pain, there's no one solution. And in fact, there really isn't. This is the thing that absolutely manages and cures chronic pain. That just doesn't exist right now. But we do know that even even if we look at the medical side of the house, the idea is that pain is multifactorial. And so if you look at patients with chronic pain, you'll often see a number of folks involved in their care. A patient may have an internal medicine provider, they may see their PCM, they may have a surgeon, they may have a social worker. So there's a lot of folks that may be involved in that patient's care. And the reason for that is that we conceptualize pain as being reflected in the biopsychosocial model, meaning, yes, there are absolutely biological and physiological contributors to a patient's pain. Again, it may have started with an injury. It may be related to how they ambulate, for example, their gait or the way they sit may exacerbate their pain, things like that. There may be genetic contributions. So there's lots of factors that can play a role, but it isn't just the biological sphere of the patient that's important. It's also what might be going on for them in the psychological sphere. What do they think about their pain? How do they feel about their pain? What are some behaviors they're engaging in? So what if you have a patient that's tensing all the time, or they're sitting a certain way to accommodate their pain, and that may actually cause pain in other parts of their body? So there's a host of these different factors on the psychological sphere. And there's also a host of factors to consider in the social and environmental sphere. So what kind of support system does the patient have when it comes to managing their pain? Are they in an environment where they can have accommodations for whatever might be going on for them, if there's a disability related to their pain, that kind of thing? This whole person approach to wellness is really important. And I give you all that context because absolutely, as behavioral providers, we have a seat at the table when it comes to treating patients with chronic pain. But I also want us to have in mind this larger picture that we are not the only piece of the puzzle, right? There are many other factors, many folks on the patient's care team that are important. And when we look at where pacing falls particularly into the behavioral realm. So we would say pacing is a behavioral intervention. And that's why I'm clicking on the screen, Jennifer, I meant to say next. Old habits die hard. That helps if I can't necessarily click on your screen. And that's why when you look at cognitive behavioral therapy for chronic pain, again, there is a range of interventions, behavioral, cognitive, things that track having patients assess how they feel about what's going on, all kinds of different, and then you see optional where it says other interventions. A lot of times for patients with chronic pain, I'm looking at involving their intimate partner, or if they have a friend or family member that's very involved in their care, I may look at communication style, all kinds of pieces of the puzzle here. So again, when I talk about pacing, I want you all to have the background that even within behavioral treatment of chronic pain, pacing is one of several different interventions. And of course, I only have you here for a few minutes today, so we don't have time to go over the whole CBT-CP protocol, but I will give you recommendation when we get to the end of the talk today for treatment manual and some places that you might look for further details. But let's go ahead and use our time today to take a deeper dive into activity pacing. All right, so next, thank you. If activity pacing is the what, I also do want to take a moment to comment on the how. We know that how we address our recommendations and how we approach and talk to our patients has an impact on how they react to us. Now, if you've ever had a training with me before, you may know, particularly with CBTI trainings, I talk a lot about the importance of motivational interviewing strategies, what we might call motivational enhancement, in terms of, hey, we've got these strategies that work. It's getting patients to do them that can be challenging. And I will tell you, I am a proponent of motivational enhancement, regardless of what the treatment is or what protocol you're using, because I think this style and this approach really helps build in the patient's internal motivation, and it really helps get patient buy-in. So I'm going to say the same thing when it comes to pacing. I'm absolutely going to recommend that you incorporate motivational enhancement approaches into pacing. And again, if that's something that you're not as familiar with, I'm going to give a shout out we have a tier 3 coming up in the new year that will be on motivational interviewing, a 2-day workshop, and it's fantastic. I have sat in it before, and we have a fantastic trainer. So, and there's other resources as well that I can point you in that direction. So the how is also important. I'm going to talk about the what and the bones of pacing, but I encourage you all, when you're bringing up pacing with patients, that you do so using motivational interviewing strategies. All right, so we'll go ahead and go to next. All right. So when we talk about pacing, there's several different variants of pacing, if you will. One of them is straight pacing, and we'll talk about that today. And I'm also going to talk about how you might increase someone's activity levels. So there's kind of maintaining and keeping them in balanced activity, and there's also ways to increase the activity levels that they're engaged in. Let's see, oh, yep, you all can see the mower here. So the idea here, and I'll go on to the next slide in just a minute, we'll talk about the pain cycle, but the idea here is that for a lot of patients with chronic pain, they may feel like they need to mow this field that you see down here in the bottom left with this mower that you see up here in the upper right, that this is old-fashioned push mower that's so effortful. And I can't even imagine having to do that whole field and what that would be like. And so when you think about your patients with pain and kind of reactivating them, if you will, this is how it might feel to them. All right, next. All right, so when folks are experiencing chronic pain, often they get into the chronic pain cycle. And as I mentioned, when we look at acute pain, we're talking about this 1 to 3 month range. And then when we hit over 3 months, it's kind of at the point where we say, okay, this is chronic pain. When folks start to experience chronic pain, what happens is that they'll typically engage in less activity. So it hurts, right? It doesn't feel good to try and mow the grass with a push mower. It probably doesn't feel good to bend over up and down to do the laundry or to do vacuuming or to stand for long periods, all kinds of things, to go walking even maybe. And so it's a natural protective response that folks with pain will engage in less activity. Well, you probably are all not surprised to hear me say, as behavioral health providers yourself, that what happens to folks when they're not engaging in as much activity as they used to? When people get deactivated, they start to not feel good. They don't feel very good about themselves or, kind of the world around them. So they have these negative beliefs and emotions about what they can do and their self-efficacy. This then, once they start to feel depressed, once they start to have these negative thoughts about themselves, now they might purposely avoid activities, not just for pain, but maybe they want to avoid social activities because, oh, my friends are all doing a morning walk and I can't keep up with them. Or my friends are, doing this volunteer activity at my kid's school, but it involves standing for long periods. And I just don't think I can do that, right? I can't do anything. And so they start to avoid even more. This leads to greater distress and disability, and around folks go in that cycle. And so people tend to, the word we often use is deactivated. People with chronic pain tend to become deactivated, if you will. All right, so we'll go to next. And sometimes this deactivation, sometimes what you'll see is that the deactivation basically looks like they're just not doing much of anything. They're just kind of sitting around. That can absolutely happen. But I will tell you what I most commonly see with my military connected patients is that they're in this overactivity, underactivity cycle where they're aware that they're not being as active as they were before, and they don't like it, and they want to fix it or problem solve it or make it all go away. And so they end up in this cycle where, let's start over here at the bottom left. Folks are deactivated, they're resting, they may spend a lot of time on the proverbial couch. They don't feel very good about that. They think, oh, I can't take this anymore. So they'll push themselves and they'll get into a period of overactivity where they're really overdoing it. Well, that's not very healthy either, in the same way that underactivity isn't healthy. And so they can exacerbate their pain and any physical symptoms they're having. So then when their pain flares up, then they have to have another period of prolonged rest. Again, they're sitting on the couch. Once that continues on for a period of time, the frustration builds, and then they'll go back into a period of overactivity. So you get this kind of cycle where there's no in the middle, right? They're kind of up and down. And let me give you a good example of this. I once had a patient with fibromyalgia. And before she had experienced the onset of her fibromyalgia symptoms, she really loved to host parties, whether it was for neighbors or for family. And she would go all out. She made all the food herself. Like, she didn't pick up trays or have catering or anything like that. They had a really big house. So she would prepare for a long time before, where she would go clean the house for days beforehand and make fancy meals and send out invitations and just all kinds of things. And then during the party, she was there she was there hosting, running around, talking, being a social butterfly. And then, of course, there was the cleanup. She would have these big parties, so there would be a lot of cleanup. When she started to experience fibromyalgia, she quit for a long period having these parties, and then she just couldn't take it anymore. So she would push herself. She got to a point eventually where she was like, I just have to do this again. And she would push herself. She had the whole party just like she had before, wore herself out, hurt herself so much that she was laying on the couch. She called into work for days. And then, a couple months later, frustrated again through another party. So by the time I saw her, she was kind of in the cycle of every couple months having these big parties and overdoing it. And so that is when she came in to see me. So let's go ahead. Okay, thanks, Jennifer. Yeah. So what we want to do, the purpose of pacing is to find a moderate in the middle. So if underactivity isn't healthy for the patient, both physically and psychologically, and overactivity isn't healthy for the patient, then what we need is to find this balance where they can engage in activities, whether it's activities of daily living, whether it's pleasurable activities, whether it's physical exercise activities. There needs to be a balance where they can engage in those things without overdoing it. And that's what pacing refers to literally. It's balancing out periods of brief activity with periods of brief rest so the patient doesn't overdo it. So let's go to the mowing the yard example that we saw in the pictures earlier. Let's say that the patient does have to mow the yard. Maybe in the past, they were used to mowing the lawn all at once and just getting it all done in a 1 to 2 hour time period. Maybe what we need to look at doing with pacing is doing 10, 15 minutes, taking a break, 10, 15 minutes, taking a break. Maybe even we have to space it out by days. Maybe we do a quarter of the lawn on one day, the next day do another quarter, the next day, and so on. However is realistic for the patient, the idea here is that there's some balance of activity and rest. So I'll go ahead and ask you to go to next, Jennifer. Oh, sorry. I think there's one.
Sorry about that, Diana. It kind of jumps quickly sometimes.
It does. I know. My mouse does that too. So one of the things that I do want to make a note of is typically when I have this conversation with patients, and I will have this exact conversation, I will say, let's talk about the overactivity, underactivity cycle. Let's talk about what happens when chronic pain takes over your life and you're not really able to do the activities that you want to do. Invariably, what I will hear from my patients is, well, I can't. I can't walk. I can't mow the yard. I can't vacuum because it really hurts. And I want to take, the caveat here that, of course, I am not a medical provider. So I do not want to be telling the patient what they can or can't do, what their physical limitations are. But I can tell you that a lot of patients don't make the distinction between hurt versus harm. And that's a really important distinction to make. So what I will do is I will typically talk to the patient's medical providers. I'll get a release to talk to them. Or at the very beginning when I'm doing an assessment and I know chronic pain is part of the picture, I will ask the patient about any limitations their medical providers have made. So going into this conversation, I already know what their medical providers would have said. Harm is in fact why we would have medical limitations. Harm refers to physical damage or illness. So let's say, for example, your leg is broken and you don't have a cast on. Of course, you don't want to be putting weight on your leg, right? That would cause further physical injury. You need to get in to get medical care, get a cast put on your leg. Hurt, though, is the physical sensation that may or may not be related to harm. So let's say, for example, someone feels uncomfortable when they walk for 5 minutes, but their medical provider has said there's no medical limitation to them walking. In fact, I think they should walk for 15, 20 minutes a day. They may feel hurt when they're doing the walking, but they are not harming the body. So hurt does not always equal harm. But for most of us, we're used to this idea, aren't we? That hurt equals harm. Because again, if we think of acute pain, it makes sense that hurt equals harm. I think of the example of, I have, the proverbial touch the hot stove. This actually happens. I have a little one that's almost 2. And a couple months ago, before I could stop her, she got over on a step stool and got up and quickly touched her hand against the side of the stove, fortunately not on the burner, and cried. And she cried a lot. And I will tell you, she has not reached out her hand toward the stove since. And she understands kind of that word hot. So the idea that hurt and harm are the same thing is really wired into us from an early age. And it can be different for folks to think about this idea that they're actually two separate concepts. And so I will tell you that when I start in the pacing conversation with patients, I'll start the conversation with this idea too, that hurt does not always equal harm. And I'll say to them, I'm not going to recommend anything that counters your medical limitations. So I am not going to tell you that if your doctor says you can't walk more than 15 minutes, I'm not going to tell you to walk 30 minutes. That's not something that I can do. But the hurt doesn't always equal harm. So I'm going to ask you to do some things that don't feel very good. In fact, that feel like they hurt, but they're not harming you. And they're part of the process of long-term improving your care. All right, so we'll go ahead and go to next. All right, so what is some good advice in general for activity pacing? So as I mentioned, when I'm talking with patients about pacing, I'll introduce the concept of the overactivity, underactivity cycle, the idea of getting deactivated. I'll talk a little bit with them about hurt versus harm. And I'll often say that, for you, hurt is probably something that's holding you back from doing your typical activities, but you're not harming yourself. So let's try to find a balance in this overactivity, underactivity cycle. Let's try to find what's reasonable and a good fit for you. Again, that may be physically uncomfortable, but that also doesn't harm you. So then we get to the part where we actually need to identify activities that we want to pace. I will tell you, sometimes I get really excited, and sometimes I have patients, particularly my military connected patients, they get really excited because I can do this, right? And I want to come up with 10 things that I can get back into or start doing again. Don't go too far too fast. I generally say the first time you talk about pacing with patients, identify 1 or 2 activities. So kind of start with a realistic approach. But what kind of activities are suitable for pacing? Really, any activities. As I've mentioned before, it could be pleasurable activities. So maybe your patient really enjoys gardening, or maybe your patient really enjoys a certain craft that they've gotten out of the habit of doing. Maybe it's activities that are activities of daily living, things that they put off or they can't do as well. Maybe it's cleaning, maybe it's the laundry, maybe it is mowing that yard. Maybe it's physical activity just for the sake of physical activity. I have so many patients that walking is something they want to do because they want to get out of the house, or particularly, again, my military connected patients, not doing any kind of physical activity can be very difficult for them and for their self-esteem, particularly if they used physical activity as coping, right, to help relieve stress. So I would tell you, really, there's a lot of activities that you can choose to do for pacing. The key for me in terms of the activity that I'm going to go with for the patient is what's realistic. So if the patient's at the very first thing they want to do for pacing is clean a 4,000 square foot house top to bottom in one day, then I'm probably going to say no to that, right? Or what was the example of hosting a Thanksgiving meal? Abby, yeah, I don't know that that's something that I would do as the very first activity to pace, right? That might be a bit much to take on. So it's just your clinician judgment, right, of what you think is a realistic activity for your patient to take on. So you want to identify the activity, and you help them identify a time period that they can do it in that's realistic. So if your patient says, oh, I can start to do the laundry, it just doesn't feel good after about 5-10 minutes. You might come up with a plan that the patient does 5 or 10 minutes of laundry and then a rest, 5 or 10 minutes of laundry and then a rest, right? So the idea is that it's okay if the time that they're doing the activity, there's a little bit of hurt, but you don't want the pain to be really severe. You don't want to get into that overactivity. So you've got to find that medium where it might hurt, it might be uncomfortable, but it's not overdoing it. And then have a defined rest period. One of the things that can really help patients be accountable to this, because again, depending on your patient's background, you may have a patient that doesn't do as much as the agreed on activity. So maybe you do say 10 minutes of laundry and they always stop at 3 minutes. Right. But you may also have patients that are gung ho and they're like, oh, you said 10 minutes, but I did 20 minutes of laundry. Isn't that better? Oh, and then I didn't feel good for the rest of the day and I laid on the couch and I didn't do anything. So one of the things that can really help your patients be accountable for this activity pacing is a log. And Jennifer will go next. That's what I wanted to show folks. Here we go. This is an example of a pacing worksheet. And I'm going to show you, I think I can put in the chat for you before we leave today where I downloaded this. This is a free download from the Treatments That Work CBT-CP manual. And that actually is a fantastic resource that I recommend for CBT for chronic pain. It's one of the sources that we used when we developed CDP's chronic pain workshop. And again, when I finish talking, I'm not always as good at typing and talking as I would like to think. I will make sure to put that information for you all in the chat. But this is a worksheet that you have access to that you could use with your patients. And so you see here that you develop with them ahead of time, what are the activities and what are the goals for their active period and then their rest period. And then each day that they do it, you have them be accountable. I wouldn't even say to you, to themselves with, okay, how many minutes am I going to be active? How many minutes am I going to rest? And then they have to record and bring it back in for you. So this can be a really helpful way of doing this. Kenneth, you ask a great question. What apps can do this instead? I typically recommend DoD VA apps. So if we were talking about sleep, for example, there's a DoD VA app called CBTI Coach that is fantastic. I am not aware that they have developed an app for chronic pain yet. There may be some private apps that might do this, but I have not vetted them. However, that said, I don't know that you need an app to do this. So if you have a patient that doesn't want to do a physical form of this, could they maybe take a picture on their phone of the pacing worksheet, mark it with a heart, mark it in that favorite way so they could pull it up and then use their notes function to track. If you want to make sure that they're doing it, could they set reminders on their phone, like alarms on their phone, or reminders that bing and say, hey, go to your notes section and record your pacing for today, or remember to do your pacing today. So I hope that answers your question, Kenneth. I don't have any specific apps that I would recommend, but you can probably modify things for phone usage, for smartphone usage. And Michelle, the apps that I typically recommend are those DoD VA apps. And I can find a link for you when I'm done talking to their page. They have a whole bunch of ones on sleep and like the Hope Box and Breathe to Relax. Things like that are developed by the DoD and the VA. All right, so next. So what are some things to keep in mind for successful activity pacing? I think one of the most important things to keep in mind is, and I know this is not out of order, I'm going to pick one of these bullets from the bottom. It's be prepared to find it frustrating. I think it's important to acknowledge to our patients that it's not fun. It's not fun at all what we're asking them to do. But you know what? Neither is sitting on the couch for the rest of their lives. And I often tell my patients when they're coming in to see me, I'm sorry. I'm sorry that your diagnosis is chronic pain. I'm not going to tell you that anything I can do is a cure for your pain, because that's why it's chronic pain. And you wouldn't believe me if I told you that. I can tell you that we can expand the activities that you're doing in your life, and we can expand the way you're living your life to better work around the experience of pain and better help you meet your valued goals of living. But is it going to be frustrating? Is it going to be challenging? Yes. Right. So I do acknowledge that right off the bat. And then I try to be as flexible as possible while still keeping the rationale. So maybe I have a patient that's really gung-ho and they really, really don't want to take these 5-10 minute breaks on the couch, to go back to the laundry example. Maybe then what we do is 5 to 10 minutes of putting laundry up or loading the washer or the dryer, balanced with 5 to 10 minutes of folding laundry while sitting. More physically demanding with less physically demanding. So there's different kinds of ways that you could do that. Another example would be vacuuming. Maybe your patient could alternate vacuuming, which is more physically demanding, with something less demanding, like then going to sit at the counter and doing any dusting or planning for the week, or making lists, shopping lists, things like that. So there's a lot of options there. I already mentioned the idea of using your phone to help engage in successful behavior change with pacing. And I absolutely think that the phone is a great tool, because your patients can put timer, they can time themselves. Like, okay, if you're gonna do the laundry, start your timer at 5 or 10 minutes so you know you haven't gone over. When to do your pacing, set an alarm or a reminder. Some folks really enjoy having music. Again, for the vacuum example, mowing, walking. People love to have playlists. I've even had patients take the time to do a playlist of, 1 or 2 of their songs, depending on, or 3, depending on how long we're going to have them do their walking, their pacing for, to remind them rather than just a timer. I do also think it's important for accountability for patients to let others in their support system know that they're going to be engaging in pacing. And so that's important. And they can also go back to their medical providers. Again, if there's not a release and I haven't already talked with them, I may encourage them to do that themselves. And then one last note, some of your patients may be on opioid medication for chronic pain. If that is the case, be aware that opioid medication is pretty sedating, even if someone's been on it long term. So I would recommend, if you have a patient taking opioids, that you don't schedule their pacing for right after a dose, if that makes sense. So if they normally take meds at 8 in the morning, you may want to have them do their pacing activity at 10 or 11. All right, next. I also want to acknowledge that for your patients that are military connected, so for your Guard patients, there are some considerations related to their military service to keep in mind. One thing is, I will tell you, and just I'll be upfront with you all, it can be easier to work with patients with chronic pain that have civilian jobs than it can for those on military duty. Why? Because oftentimes civilian employers, they want to be accommodating. They might legally have to be accommodating. They may be willing to, say, bring a chair or something like that. When it comes to military duty, it often involves more physically demanding tasks, and there may not be capacity to be accommodating. Maybe it's a field exercise week and everyone's out in the field and there's just no way to get a chair for the patient to periodically sit on. If that happens, you're going to have to talk with a patient about, okay, you may get out of the habit of pacing while you're on duty, but what can you do when you return from duty? So if you're Guard and you're coming off of active orders as you transition back into your civilian job, how can you get back into the habit? If you're on ongoing military duty, what can you do in your off hours to make sure that you're pacing or balancing your activity out and getting some rest in there? I also want to note that it can be really challenging if you're engaging in pacing to prepare for PT testing. I will just put that out there. PT testing can be very stressful. Those of you who are prior service or current service may know what I mean. And there's really can be that pressure to push yourself. In fact, I knew folks that would deliberately load up on pain medication prior to their PT tests so that they could run on mild injuries or push themselves further than they could otherwise go. So that's absolutely a consideration. If you feel, and the patient has not shared with you that they're already talking with their unit about their pain-related limitations, this is where I would absolutely say, I think you should tell the patient to go back and talk to their unit. Because if they're not feeling like they can engage in PT testing, that's something that their unit needs to be aware of. They may need a waiver or evaluation on the military side. So I do just put that out there as well. And one thing I will say is, yes, it may be more challenging to work with service-related limitations. There's also a benefit, though. When I work with my military-connected patients, initially they may say, well, I have to be tough and I have to be strong and I have to push through this. Pain is weakness leaving the body. No pain, no gain. I hear that ad infinitum from my military-connected patients. But what I will tell you is, if we can reframe that narrative for them and talk with them about this idea that pacing isn't actually limiting you. What's limiting you is overdoing it to the point of exhaustion where you can't do anything for a while because you're not very effective. You're not maximizing your effectiveness and your potential in this cycle of back and forth. But pacing rather is a mission enabler or a force enabler. It helps you to get what you need to done in a realistic way for where your body is at right now. And so again, I think that how we, I mentioned earlier the how, right? And using motivational interviewing strategies is really important. I think the how of pulling in military culture is also important when we're implementing pacing with those patients. All right, next. All right, so lastly, I just wanted to give you an example of how we might incorporate pacing into a treatment session. So what would a treatment session where you're covering pacing look like? All right, I'm so sorry, Jennifer. I think this is animated. I forgot to take all that out. If you could click all the way through, and if it goes too far, just go back to the next one. I apologize. I meant to remove that. So as I mentioned, what I will typically do in that appointment is I'll start out with psychoeducation about the overactivity, underactivity cycle, hurt versus harm, and I'll revisit with them what their medical provider has shared with us, whether it's to me directly or to the patient, about their actual limitations. Once we're on the same page with that, I'll then move into this concept of activity pacing. And one of the things I like to do is I'll say, look, if the problem for you is these cycles of overactivity with underactivity, then the fix or the opposite of that is moderating that. And that's what I want to talk with you about today. And the kind of moderating we're going to talk about is called activity pacing. And that's when I'll introduce kind of, again, the details of pacing, the rationale, and I'll bring out the worksheet. And together with the patient, I will help collaboratively plan what the pacing is. My favorite thing to do is to turn it back to the patient. So rather than me telling them what to pace, I'll say, what's something realistic that you could start with pacing this week? What's something that is an activity or a task that you've put on the back burner that you need to be doing, like buildup of laundry? Or what is something that you've gotten out of the habit of doing that you miss, like walking? And I will let the patient come up with what they'd like to do. Again, we may need to guide. We may need to say, oh, that might be okay. Having the entire extended family of 30 over for Thanksgiving as your very first activity to pace may not be the best thing. But is there something else, something like a smaller gathering we could start with? So you may need to set the tone for that. And then if you were previously engaging in activities with the patient designed to target their chronic pain, like relaxation, that's one of the very first things I'll do for my patients with chronic pain is set up a relaxation protocol or plan. I will remind them that pacing doesn't replace what we've already talked about, and I still want them to keep doing whatever it is they were already doing. All right, so next. There's a few more slides that I have for you all. We don't have time today. I included them in, and so you'll get copies of them. I don't have time to go over them in as much detail, but they're there for you for your reference. What these slides reference is the idea that sometimes, oftentimes, hopefully, your patients will get to a point where they're going, I need more than just a moderate pacing. I actually want to pick an activity that I can increase. So let's say your patient chooses walking, and maybe they say to you, you know, I can walk to the end of my street. There's a bench or a place I can sit there. So I walk for 10 minutes, sit at the bench for a few minutes, walk home, and then rest. I can do that. But I want to do more than that. I want to go beyond the end of my street. I want to go, to the next street over. I want to make a loop through my neighborhood. I want to get the most that I can eventually down the road. And that's where graded activity comes into play. It's the idea that the patient can gradually increase their activity level once they have pacing established and once they know not to overdo it. So Jennifer, if you could click next. This would be a typical example for someone who's gotten into an underactivity cycle, right? So they start out with doing a lot and then the pain hits, and then over time they gradually do less and less. And then this is animated too, Jennifer, I'm sorry. So if you hit next, it will show, and this is kind of this overactivity, underactivity, where too much, nothing, too much, nothing. And then the last one is graded activity. This is for something that the patient wants to increase. Maybe they do a little bit, take a rest, do a little bit, take a rest, and gradually increase over the course of time. When it comes to physical activity, one of the most common models in CBT for chronic pain is the 10% guideline. You don't always have to play hard and fast with this, but let's say your patient's walking for 10 minutes. The 10% guideline says maybe every other day they could add a minute to that. Or maybe they need to stretch it out and do every 4 or 5 days. It's really what is realistic for your patient, but it's about 10% increments over time that you gradually move. So next. What you do want to do with graded activity is, as with the same thing you would do with pacing, find a place for them to start, a baseline that is something that may hurt, but is not not really causing them excessive pain or harmful. And if you go next, Jennifer, the way that I often do this with patients is I'll ask them, and you can see here, let's say they want to do cleaning and they want to be able to spend more time cleaning in prep for Thanksgiving. Maybe you would ask the patient something like, well, how long have you spent before cleaning the house and had a pain flare up? Oh, well, 2 hours. Okay, well, we don't want to start out 2 hours as the baseline to do your pacing and potentially increase your activity. What about half that time? If you did half that time, would that cause a flare up or a really strong increase in your pain? Oh, yes, an hour would do it. Okay, what about half of that? Would 30 minutes cause a flare up in your pain? Probably. And you keep going until the patient says no, I don't think that would cause a flare up. This example here was 15 minutes. So this is a patient that we worked with on cleaning. It was cleaning the house was her example. And we started with 15 minutes. And then gradually over time, we were able to increase, where 1 week she was doing 15, the next minute she did 17, or the next week, and then the next week 20. So next, Jennifer, if we go. I've already talked about these, so we can click through this animation. You all already know that sometimes these things can hold the patient back. But the biggest take home that I want to share for both graded activity and pacing from this slide is that you heard what I just said, that it can be slow going, that like the patient may be used to do all this. I can clean this 4,000 square foot house in one setting, or I can jog 1.5 miles and I don't know, I can't do it in 10 minutes, but run 1.5 miles in 10 minutes. I can do all of this. And now you're telling me I have to break up cleaning over the course of a couple days, or now you're telling me just to start with walking 10 minutes and then go up a couple minutes each week. And so part of this is the patient being gentle with themselves and being patient with themselves to realize that this is where they're at right now. And it may not be where they're at forever, but again, in terms of realistic expectations, we want them to take good care of themselves, right? And be their own cheerleader in a way. All right, so Jennifer, if we can go through the next, let's see, we'll kind of go quickly through these. I'll let you all look over these slides. This is very similar to what I had with pacing in terms of choosing activities that could be fun, choosing activities that could be daily living or physical activities. And eventually down the road, not right away, but eventually down the road, you can pick some activities that the patient has been completely avoiding that maybe might cause them a little anxiety, but are not medically contraindicated. And you can use the pacing worksheet that I already showed you all to track graded activity, so you could increase their goal week by week. I'm going to skip the case examples because I think we've shared, in fact, this example we have here about walking is pretty consistent with the activity or the examples I've been sharing throughout. And we can skip this one as well. This slide is just showing that a lot of patients with chronic pain, that's an example of putting goals together that I had with a patient with chronic pain. And that's just an example of how a lot of patients' goals do relate to activities that work very well for pacing and increased activity. So things like mowing the lawn and folding laundry, like we've talked about, lend themselves very well to pacing. Walking lends itself very well to gradually increasing that activity or graded activity. And just know if you're working with this patient long-term that there's probably going to be setbacks. They're going to have flare-ups. They would probably have flare-ups if we weren't doing pacing or graded activity. So that's okay. And it doesn't mean that they're a failure. It doesn't mean that you're a failure as a provider. It just simply means that that's common in folks with chronic pain. And it's more about the maladaptive, I wouldn't use this language with the patient per se, but it's more about the maladaptive responses. So it's about responding in a way that's kind of overreacting or panicking that's more harmful than the actual flare-up itself and learning to get back into pacing and activity. And that would be the adaptive response of, hey, it happened. It's okay. It's going to happen. I just need to get back into my pacing or my activity. And I may need to, if I was up to walking 20 minutes and I have a setback, I may need to go back to 10 and work my way back up. And that's okay. All right. I think, Jennifer, did I get through the end? I was so ambitious. I did. All right. I was so ambitious. I just had so much I wanted to share with you all. So I know there were some slides that we didn't get to talk about in as much detail, but they are there for your reference in the copies of slides. So I hope this was helpful in looking at, if you have patients with chronic pain and they've gotten out of a lot of valued activities in their lives, ways to get them back in. Jennifer, I was looking in the chat. I think I caught most of the questions, but if there are any questions, I'm available. Happy to answer.
We did have one question that was asking about whether we'd be able to share the slides, Diana.
Yes, and I think that's okay. We typically share the slides in the past, I think.
Perfect. So we will absolutely share that with everybody. I think you do have one more question that's come through in the chat there.
Oh, good. Let me take a look. Yes, and so that's a great question. So the question in the chat is, if they experience a flare up after doing the activity, would you reduce the time? I think I would say it depends. If it's a flare up that happens one time, I might ask them to try an experiment and try one more time to see. The reason I mention that is that sometimes folks will sell themselves short, if you will, and they'll try it one time and they'll panic and then they'll kind of go back. If they've tried it a couple times and that consistently happens, then yes. Alternatively, if you have a patient that is not going to continue doing pacing at all, and they come and say, I had this flare up after 30 minutes, I'm not going to keep doing 30 minutes, but I'll keep working with you if we can tailor it down to 20 or 25, I'm going to go with that. So Jennifer, I realized that was a very broad, it depends answer, but it really does depend on where the patient's at and what they're willing to do.
Yeah, it sounds like it might be one of those situations where you need more information to really determine what that ongoing plan is going to be. That makes sense, Diana. Sherry, I see your question about a certificate that we do not offer CEs for the coffee and community call. So that's not something that we provide after these calls. Good question, though. Thank you for asking that.
And
Looks
I'm
like you're
going to
getting lots of positive comments there in the chat. And Diana, one thing that I had pulled up that I'm wondering if it might be helpful. I know you mentioned that you are going to share that pacing sheet with everyone. And then I also have, I can share that in the chat, the VA's site for management of chronic pain.
Thank
There's
you. Yeah, and the VA has done an excellent job with putting out chronic pain resources. Jennifer Murphy is their primary POC, Dr. Murphy, and she has some fantastic videos that are open source available on that website link. So that's the provider manual, I think, Jennifer, that the VA has. But Dr. Murphy also has some videos up on the VA site as well that are fantastic. In fact, we borrowed her videos for our site.
perfect. Yeah, it looks like they have some example videos with vignettes on there, which could be really helpful for folks who want to continue learning after the call. There was some interest in the app, so I did throw that link in. I'm just throwing it back into the chat if anybody missed that earlier. I also did not see anything, Diana, of a specific VA chronic pain app. I did search for it and couldn't find anything. Sounds like somebody may have a question.
Okay, bye. Okay, bye.
It's the hot mic.
Okay. Well, Jennifer, I'll turn it back over to you. But in the meantime, I'm going to look for that. I put the link to the book, the Amazon, if folks want that particular manual. I'm going to keep looking for the open source handouts link when I turn it over to you, and I'll put that in the chat shortly.
Perfect. Sounds great. And Michelle, I see your comment. You've used PTSD Coach. That's really useful. That mindfulness app they have, that Hope Toolbox. There's a lot of great ones. Actually, if there are ones that people really like, you want to share that in the chat, please feel free to do that for the good of the group. That would be really helpful. Thank you guys all for attending today. This was really well attended. I think this is a topic we really haven't gotten into a lot on the coffee call, so I'm glad you were able to make it. I mentioned several kind of training opportunities at the beginning of the call. I do want to share our admin support box if anybody has any questions after the call and you want to reach back out to us, or you're curious about any of the trainings that we've mentioned, please connect with our team so we can further assist you on that. I do also want to highlight, you may have seen an email come through recently asking you to go into your provider portal and be able to notify us on the SBHP team. You can kind of toggle off and on whether you're accepting referrals or not. If you haven't logged in to do that, I really encourage you to log in, update that. As a person who also uses the registry to help soldiers find care, it is so helpful to have that accurate so that we can make sure that we're getting folks connected as quickly as possible. So again, if you haven't logged into the provider portal, if you have any questions about how to do that, please reach out to our team. We're happy to help get that information to you. We are working on some updated policies and procedures. If you have any input about how to better manage that referral process through the make a referral button, or you have questions or suggestions, we'd also love to hear your feedback on that and welcome that input in that help support box as well. Anything you want to add, Christy?
No, I think you
Before we
covered
sign
it
off?
all. It was very exciting to see everyone here today. So we will see everybody back in October for the first call of our new fiscal 24 year, where we are bringing on 14 new states. I've lost track. So hopefully this call will continue to grow. So we're excited about
16,
that.
yeah, okay.
16? Oh my gosh, I think I'm in denial.
Yeah.
I think that's